Hi, I'm Dr. Connor Nichols with the emergency department. So we're going to talk about the evaluation of the internal jugular, or IJ, today. So when you've got a patient that you're thinking about doing an IJ on, you obviously want to take your linear probe, and this is the smaller footprint. Down in the emergency room we have the larger footprint, and all that is just this longer across. This is actually probably better because sometimes people's necks are fat and there's not much room. You want your indicator to your left, okay? So you want it to correlate on the screen. So what I can do to make sure is I can kind of tap here, and you can see that I'm seeing movement up there by the indicator. So I know that that is my left side and that's medial. And then this is going to be lateral over here. So a lot of our septic patients, you know, they're breathing really fast, so their IJ's collapsing, or maybe it's not that big. So when you're taught to do IJs, a lot of people are taught to move the neck like this. You want to turn your neck all the way to the side, but look what happens on the screen when you turn your neck all the way to the side. It actually makes them more on top of each other, versus when I roll him back, it's less on top of each other. So it's actually better to do it more straight. It makes it a little bit more difficult because his chin, but you know, the more that you can do it straight rather than all the way turned to the side, the easier it will be. So what we want to do is we want to look at the IJ, which is going to be superior to our carotid, obviously bigger usually, and more collapsible. So what I'm going to do is I'm going to press in, and you can see it collapsing, and I'm going to hold it. And so the IJ is completely collapsed, and you can see the carotid pulsating there. So that's what you want to know. The IJ is not pulsating, the carotid is pulsating. So what you don't want to hit is that carotid. What we're going to do is we're going to look at this on the screen. This is 3.7 centimeters. So let's just say 4, so half of that would be 2. So each of these are half centimeters. So half, 1, half, 2. So he's about 1.5 down would be the center of the IJ. So you want to have an idea of that. Make sure you don't press too hard when you're holding the probe, because you don't want to collapse it, because it's easy to collapse it. And then I'm right-handed, so obviously I'm going to have to hold it with this hand. So I want to have my hand down on him so I'm steady and not in my field of vision. So I'm going to want to, you know, clean before that and go in, you know, remember our Pythagorean theory again from other peripheral IVs, that you want to go back about the same amount that you have to go in depth. So for him it would be like 1.5 centimeters, so we want to go about 1.5 centimeters back at a 45 degree, because you want to be able to adjust that needle to where you're not hitting the carotid. So if you're not getting a good IJ, you can always put the patient maybe in reverse Trendelenburg, and then see if that will make your IJ larger. You can look at the other side, see which side is better. Indicator to my left. So his right looks a lot bigger than his left. So there's our right, and again, there it is collapsed. There's our carotid pulsating. And now we're ready to go. So we've talked about transverse, which is what we typically do for, I mean, you can do sagittal or transverse. Now, this probe is smaller, but you know, our larger probes in the emergency room are very difficult to get in longitudinal on somebody's neck and have enough room for you to put the needle in. The other disadvantage is that obviously we're trying to avoid the carotid. So in transverse, you can see the carotid. You can see it in longitudinal, but it would be easy to go off plane and think that the lower carotid is your vessel. But if you want to look after you do the procedure, after you have your needle in and your guide wire in, then you can turn in transverse or in sagittal, and you can see the guide wire a little bit easier and kind of pan through, and you can see it lying in the top vessel.